Want to get next to somebody who has a copy, that would be probably the best way to. I'm just going to read it. So if you want to just listen, that's fine, but some people do better with a copy of it. So I would really like to hear from you all the end of my reading here. So if you do have any questions, that would be great if you could just jot them down so I can kind of whiz through it. And here we go. A call to subjectivity, women's experience and Western psychology. That psychology is a male norm discipline has serious implications for the articulation of women's experience in Western culture. The consequences of adhering to a white, privileged male norm are faulty overgeneralizations, exaggerations of difference, and evaluations of deficiency. This paper counters the oft-repeated androcentric foci that reinforce a generic view of the human experience by submitting that women's experience is gendered and therefore particular. Before I begin the discussion of responsibility, freedom, and justice in women-centered psychology, I will situate myself within the current discourse involving gender. I'm just going to summarize this for you, and if you want to go back to it, that's great. Basically, on one side, we have those who maximize gender differences or overemphasize, which presents false dichotomies. And then we have those who gender blur, and that sort of presents an androcentric or a androgynous focus. And where I stand is more of acknowledging and affirming gender differences. So we can pick up on page 4, where it says the first full paragraph says, the affirmation of gender differences is the third dimension of the gender debate considered in this paper. I identify myself with this position, which suggests gender differences must be carefully acknowledged and investigated. I posit that these differences have placed men in the position of normative and women at the margins of human experience. Further, gender affirmation must be coupled with an understanding of the intricacies within feminine experience. The diversity of womanhood is considered in order to present a fully particularized version of women's lives. In light of this paper considers the responsibility, justice, and freedom, instruments for the psychological and cultural affirmation of women's experience. Responsibility, freedom, and justice serve as the framework from which the subjectivity of women's gendered lives may be affirmed and explored. In order to free women from the generic view of humankind, men and women must take responsibility for the desubjectivizing of women's experience within Western psychology and culture. By working towards a psychology of justice-making, women may circumvent the pervasive, universal, and generic assumptions about their experience and experience the freedom available to them. So, responsibility. Both women and men in the field of psychology carry the responsibility of challenging the generic view of human nature and meeting it with a strong rebuttal. First, there exists a responsibility to address universal assumptions about women's experience. Second, attention needs to be given to differences in power and resources between men and women. Third, women's needs, values, beliefs, themes, and symbols must be identified. And fourth, women must claim their unique personhood. The first responsibility of humankind in understanding the particular meaning of women's experience, both psychological and spiritual, involves recognizing universal assumptions of women's experience. I'm just going to touch on these rather than reading them word by word. The first one is that women are a homogeneous group of people working toward the same goals, when actually women differ from one another in a multidimensional manner. I just consider here the universal woman, which is really a myth. And not only are men and women different, but obviously women to women are different. And what has happened in the feminist movement historically is that the white, upper class, privileged women have sort of been the main voice. And in the 1980s, we started hearing more from Asian feminists and Latinas to make the body of literature more full. So a few of the issues of diversity among women include class, sexual orientation, ethnicity, physical ability, age, and religion or spirituality. The second false assumption about women's experience is that all women are conscious of the oppression and discrimination that confronts them. They may not wish to stir the waters, and as a result, they deny patriarchy and repress the feelings they have regarding the oppression, discrimination, and sexism they may experience. Others may not have the time or education to evaluate such matters. Third, it is assumed that female gender roles and sexuality are valued. For within the family, a woman serves as mother and a man father. Although there exists a dearth of positive ethical values enabling both sexes of the same generation to form a creative, not merely procreative couple. Giving back cultural value to female gender roles and sexuality may be one way to ameliorate this phenomena. And I'd like to just mention a little caveat here. I'm fully aware that there are other lifestyles and other ways of working creatively in life, so I don't wish to exclude any other kinds of lifestyles or family configurations. So these universal assumptions of women's experience must be replaced with individual narratives embedded within particular contexts in order for a women's subjectivity to emerge. The second responsibility involves acknowledging differences in power and resources between women and men. The decline of a gendered culture goes hand in hand with the establishment of supposedly universal values that entail one part of humanity having a hold over the other. Patriarchal power is organized by submitting one gender, women, to the other, men. There are grave psychological ramifications for this domination. In order to rebuff the cultural domination of men over women, men must be willing to surrender and share their individual power with women, while representing women to other men by standing against oppression and sexism and promoting equality. The third responsibility of women and men for the subjective experiences of women is to examine the needs, themes, values, and symbols that characterize a woman's experience. These are the elements of contextualizing women's lives. This paper assumes that women need to give voice to their subjective experience. Whereas traditional forms of psychology have excluded women's experience, a woman calls for an arena within which she may be heard and allowed the time and space to formulate her version of her life. Women need women and men psychologists who are interested in listening to, encouraging understanding and insight, and interpreting their narratives. Then I go on to some themes of women's experience, and I'll let you just look at those on your own. Thwarting the adverse effect of universal assumptions of women's experience by attending to the aforementioned responsibilities may culminate in the articulation of a woman's subjective experience. A woman may achieve a sense of her subjective narrative once she says no to being defined as the universal woman. A woman must discover her own subjectivity apart from all the years of patriarchal interpretation, and she must do this herself in her own particularity, not as some inaccessible universal woman. It may be best for the mental health of women, without ceasing to put gender differences into words, to situate themselves as I, to represent themselves as subjects. In order to obtain a subjective status equivalent to that of men, women are responsible for gaining recognition for their differences. They must affirm themselves as valid subjects, daughters of a mother and a father, respecting the other within themselves and demanding the same respect from society. Through this process of helping women understand their subjectivity and returning to them a sense of self and vision, women may experience freedom in psychotherapy and hopefully in the larger culture. Freedom. Humankind may also take part in this project of freedom by implementing psychotherapy centered on understanding unique women's experience, including spirituality. Key to understanding the subjectivity of women's experience is looking beyond the objective, removed forms of psychotherapy that run rampant in the history of psychology and employing alternative models. The patriarchal order does not appreciate the real value of the world we have and draws up its blueprints for existence on the basis of hypothetical worlds. Patriarchal civilizations have repressed one part of social reality and now have difficulty in rationally envisaging justice. Thus, psychologists stand the risk of becoming deadened to the great project of healing individuals if they adhere to the universal objective stance of traditional psychology. Value-free objective models put the psychologist at risk of losing the importance of the relationship and the human connection between client and therapist and becoming apathetic to the healing of persons. The therapeutic relationship runs the risk of running dry if it is not deemed relevant by those practicing it. Subjective reality must be respected and taken seriously. Particularity, the context of the person's healing, comes from her tradition, her narrative. In contrast to patriarchal models, women-centered psychology fosters justice by bringing to life women's narratives in their own words, according to their truth. This requires the development of women's view of reality and the transformation of constraints of traditional psychology. This kind of unique respect for women's experience in psychotherapy may provide the necessary components for satisfying the anguish, the suffering, and the hopes of women. Through this dialogical, mutual process of understanding the woman's narrative, a collective history and a personal reality may emerge. A particularized psychotherapeutic approach would allow for the entirety of a woman's experience to come forth. In addition to the concentration of therapeutic skills on the articulation of women's subjective experience, psychotherapeutic containment of the emotions inherent to a woman's experience of an androcentric culture may be liberating for women. Oppression, hierarchy, objectification, and misogyny are only a few of the negative cultural factors that women may need assistance in containing. Through the internalization of oppression, domination, dehumanization, and misogyny, women may feel demoralized and imprisoned. The therapeutic task is to understand the way in which women have made meaning out of these confining cultural messages and assist them in developing an identity that is couched within their subjective narratives. Part of the freedom in a feminist psychotherapy is that it provides space for the re-emergence of spiritual dialogue. Brown asserts that the Jewish term tikkun olam, the redemptive act of the healing of the world through the healing of persons, is one way of conceptualizing therapy that destroys the patriarchal internalizations. Her position is that the feminist therapist's objective is to help the client refute the disruptive patriarchal attitudes and beliefs within. In this way, the culture becomes the patient. The project is ending the internal oppression of women. This commitment is the sacred act of the feminist project. Freedom from oppression may emerge through the acknowledgement that women need a representation and celebration of conception, birth, childhood, adolescence, the female festivals, and female suffering. It is these particular representations that provide the framework for women's narratives that culture does not provide. The cultural affirmation of women in the rich artistic and symbolic representations of women across cultures indicates that justice-making occurs in an unjust culture. Western culture is imbued with the many Greek, Latin, Asian, Jewish, and Christian traditions, at least through the art, philosophy, and myths we live by, exchange, and perpetuate, often unknowingly. Feminine art and other forms bring women closer to self, God, body, emotions, and history, making them able to live without contempt for their incarnation, for that of mother and other women. Peace with oneself, God, and others ushers humankind into a psychology and a culture of justice. Justice, the responsible investigation of confining culture and interpersonal aspects of women's life, bring liberation, which results in justice. There is justice in listening with a curious expectancy to women's narratives. There is justice in owning the imperfections and adverse forces within American society that serve as barriers to women's articulation and adverse forces of their subjective experience. Justice is also an integral element of the freedom found by women in understanding the interplay between their experience and culture at large. Justice is here represented in the return of communal righteousness and peace. The enjoyment of the fullness of one's subjective humanity is the outcome of justice-making. Justice is found in psychotherapy that encourages the subjective articulation of women's experience by women and for women. Feminist therapists must address the symbolic meaning of women's experience and recognize the inherent value of the process, the connection, and the work of relationship building and justice making. Women-centered psychology serves as a mediator between female subjective experience and cultural pressures and expectations. That is, it serves as a facilitator of meaning-making for women in that it provides an avenue for the interpretation of cultural narratives when juxtaposed to the individual's internal and spiritual narrative. Women-centered psychotherapy attends to women's needs to understand and feel the ramifications of existing in a patriarchal culture. Psychotherapy may serve as a place in which women may translate their experiences in a larger culture into a subjective narrative enhanced by the examples of women from their spiritual traditions. And then I list here a psycho-spiritual model of a woman receiving herself and being received by culture, and then in turn her being able to receive others. So I'll leave that up to you to look at that. So in conclusion, it has been suggested that traditional Western norms for psychological practice and study have excluded women. This generic view of humanity has perpetuated the silence of women and the lack of respect for women's subjective narratives. I proffer that women and men must act as cultural agents responsible for the restoration of women's particularity within a universalistic culture. Moreover, by acting as responsible participants in the community, women and men may promote freedom for women from the obstacles that confine them to a generic existence. Finally, the restoration of peace and righteousness to individuals, families, and communities is the result of justice-making in psychology. So that's what I have to offer today, and I'm not sure how much time I have left, in about 5 to 10 minutes. So if you have any questions, feel free to, or just comments, feel free to ask. While you were talking, I was just thinking about how most personality theorists and psychologists throughout history, they've been men, like, say, Freud and people following him, but the majority of their clients and patients were women. And so I wondered if you could kind of comment on that, because they're creating their theories, and they're mostly men creating the theories, so they might have a different understanding, but yet most of their patients would have been women. So I was just thinking about that, wondering if you had any thoughts about that.
I have some initial thoughts. What I thought of was just the initial psychoanalytic, the fathers of psychoanalysis and thinking about their patients were women. And then through their work with their analysts, they came to develop their own theories, like Melanie Klein, Anna Freud. So there has been some involvement of women in developing theories, but I would say they're not typically mentioned. The books that I enjoy reading in response to that, let's see, Women's Growth and Diversity, that's published by the Stone Center, by Judith Jordan, and Carol Gilligan's, what's the name of that book? I can't think of the title, but Carol Gilligan has written in response to Erickson's theories and Kohlberg's theory as well. So she responds to a more generic universalistic theory in a women's perspective. Mm-hmm. Anyone else? Oh, do you have your hand up? Okay.
You mentioned a particular narrative for women. The particular narrative in women. Through your research, have you found any relevance then in meta-narratives for the particular from a woman's standpoint?
What I've come to understand about meta-narratives is that there really aren't any in this postmodern era, that they're more about the individual particularized narrative. So my limited understanding of the meta-narrative is that it's no longer I don't know that it's not relevant. I think it's relevant, especially considering the historicity of it, that it provides a background for what women are thinking and doing today. But my understanding of it is that it's more of a modern notion that there is a meta-narrative, that the postmodern person might believe that there is none. However, with faith traditions, I think that there are some certain underpinnings that might create somewhat of a meta-narrative. So that's sort of an exception, I would say. Thanks. Anyone else? Thank you.
Okay, can everyone hear me? All right. Well, I'm going to be making use of a tape and of the overhead today. I have a paper. Now, this isn't specifically related to what I'm presenting today, but it is a general theme So I think I've got enough for folks. If you want to read this later on, that'd be great. But if you're trying to follow along with me, you'll get lost. So just kind of let you know. Troy, would you mind handing these out? Oops. Thanks. Okay. Is that clear to folks? Can people see that? Part of the, I'm assuming it's probably this right here. Okay. Try again. Oh, there. Okay. There we go. All right. Thank you. Okay. All right. What I'm going to be covering today is existential themes and the cognitive behavioral treatment of anxiety disorders, and in particular OCD, obsessive compulsive disorder. My interest in anxiety disorders, I've always had an interest in anxiety disorders, but particularly it's been over the last year. I'm from, I go to University of North Texas, which is about 50 miles north of Dallas, 50 or 75 miles north of Dallas. And there's a neighboring university there, Baylor University. I'm sure you've all heard of it. And so I did a practicum there. And we treated exclusively people with anxiety disorders, panic attacks, obsessive compulsive disorder, generalized anxiety disorder. And so I really became interested in this topic. And what I'd like to do today, kind of one of the objectives, is to talk a little bit about OCD and how OCD is kind of a tricky disorder. It often will mimic things that look like kind of existential or religious issues. And indeed, I think these issues are definitely worth pursuing with individuals. But at first, when people come in with these compulsions, and I'll go more into this a little bit, you can really make things worse by kind of engaging in this dialogue with them about the religious and existential stuff. And so OCD is really a tricky disorder, and the kind of meaning-based work you want to do with these individuals really comes after you do a lot of behavior therapy. And this is a really important thing because as ethical psychologists and counselors, we want to make sure that we're helping our patients and not making things worse. Let me talk a little bit about, I guess briefly about my experiences there at Baylor. I've seen people with obsessions that they were horrid fears that they were transsexual. There were heterosexual individual, for example, was deathly afraid that he was a homosexual, would spend hours and hours doing compulsions. I've seen kids, and they've had a lot of religious rituals and things like that. Trichotillomania patients, the ones who pull their hair out and things like that. Seen those. So I've seen a general pattern among these people, and it's really been a really interesting experience. So let me talk a little bit about the diagnostic criteria, and I'm going to defer to the DSM, although that should be taken as kind of the general criteria, and I'll talk about this, and there are certainly exceptions and things to what the DSM says about OCD. But obsessive compulsive disorder is people have either compulsions and or obsessions. And it's really important to understand kind of what the differences are between these two. An obsession is an intrusive thought or an image, something that somebody experiences. It's ego alien. And what I mean by ego alien is they know that this is not part of their belief system, or this isn't part that they want to experience. It's just something that kind of comes into their mind over and over again repeatedly. And obsessions usually take about three main forms. And the research has shown that it's usually sex, religion, / include existential or maybe hypermorality, things like that. And the third one would be violence or harm. And that third one, the violence or harm, is how I'm going to talk a little bit about this patient later on, because she had some 911 obsessions. It was real interesting how we treated her and how we didn't get caught up into, in the beginning, into doing some real depth psychology, which could have made this kind of worse at the beginning. So compulsions now are, so that's what an obsession is. A compulsion, and actually a more accurate term would be a neutralization. It's something that the person uses to neutralize, to reduce the anxiety that's associated with this obsession. So kind of the classic one would be you've seen the hand washers, the folks who wash their hands, hours and hours a day. Their obsession is the fear of dirt or contamination. And so in order to reduce that anxiety, they engage in these neutralizations or these compulsions, and they wash and wash and wash and wash in order to feel clean. Okay. And what are the most frequent kinds of compulsions? We find washing, we find checking. There's also some folks have symmetry, which are really difficult. One of the most difficult compulsions to treat is hoarding, and there's new stuff coming out on that in the research. Very interesting stuff, very difficult to treat. Okay, let me just, epidemiology here. Let me just talk a little bit about who has OCD, what is, in terms of that. In the United States, 2 to 3% of Americans have OCD. Okay, it's a chronic, lifelong disorder. It can get better. OCD usually starts around the age of in adolescence and adulthood. Usually, though, by the time you're 35, most of your obsessions and compulsions have pretty much come out. Okay. Children can have them. Like I said, I've seen some kids with this. In Canada, I'm sure rates are probably much similar or the same. Unfortunately, I haven't found anything that talks about like a global, in other countries and things like that, the prevalence of OCD. Why do people have it? That's the big question. Why? Links to biological theories, environmental stressors, developmental problems, all sorts of things have been postulated. Probably what the research has said the strongest link is probably biological kind of temperament or a biological disposition that's kind of exacerbated by stressors. So that's a little bit about OCD and how it. So it is not that common, but we're finding out more and more that a lot of the anxiety disorders have similar patterns that are associated with OCD. So I think it's relevant, and even just for a lot of general anxiety disorders and things like that. Okay, let me go on and talk a little bit about what kind of the gold standard treatment is. And are you familiar with that term, gold standard, like what they consider the best? Basically, gold standard means like what is the best treatment for somebody who has OCD. It's this term called exposure and response prevention. And let me just spend a minute explaining what this is. Basically, like FOA and others have found that if you have a patient or a client who has obsessions and compulsions, what you can do is, if you persuade the client not to use their compulsions, okay, and to instead endure the anxiety associated with the obsession, as Viktor Frankl would say, is to face the thing that's causing them the greatest fear. Okay, if you have them do that and paradoxically expose yourselves to these obsessions, in time the brain will habituate. In time the brain will learn that this isn't as fear, as fearful. And I bring up Viktor Frankl because, well, one, this is a meaning conference, but two, Frankl had a lot to say about OCD and anxiety disorders. And I wrote an article about his ideas because they haven't been really out there as much. But he talks about a lot of the same things, and I think they add kind of a deeper way of looking at OCD. And I'll get to that later on a little bit. Okay, what are the limitations with this kind of, call it like a blunted axe approach, where you're basically exposing this person over and over and over again? Research shows it does work, okay? But there are problems. There's relapse, okay? The obsessions can transform themselves. Yes?
How would you expose somebody who had one of these religious compulsions that you were
Right.
talking about? I mean,
Sure.
You can't expose them to God. Or is it,
Right. Good question. Yeah. Matter of fact, we had some folks like that. And what we do is a lot of them, what they'll do is their neutralization, their compulsion will be like praying for like 5 hours a day or something. Now, this isn't, I'm talking about an intrinsic faith. I'm talking about they feel compelled to do this because they have an obsession, and the obsession can be that they are contaminated, that there's something wrong with them. So what we would do is we would persuade them little by little to stop the compulsion, which would be the excessive prayer, and in that situation to expose themselves to this contamination fear of their dirtiness or whatever it is, and in time that original fear would decrease. Okay. Now I'm not saying stop praying. That's not what we're trying to say. I mean, later we can talk about balance and things like that. But initially, it's important to see this as a ritual. Does that help? Can I answer? Okay. Great. So the limitations of this exposure and response prevention, and kind of tying into what question that I answered there, is that some people don't seem to have these compulsions. Some people just have obsessions. And it's real hard. The literature talks that there might be mental rituals. You've heard like some people might be counting and counting the tiles or using distraction. But it's real hard to just, elicit this information a lot of times from clients or from patients. The other thing is some people just don't report that they have rituals. They basically just have these obsessions, and it's kind of like, well, what do you do? Because the whole idea is you prevent the compulsion, right, so that you can expose them to their obsession. Well, what if they don't have a compulsion? So that's a problem. Other things is the presence of access to disorders, people with personality disorders who have little insight, who just are not, don't really want to do the work because they're just so filled with so much fear, avoidant personality disorders, and all these other personality disorders and things. Schizotypal, they may have little insight into the disorder. So those are complicating factors. Okay. So the pure obsessives, we call these the pure obsessives, they have the most problems. So those are the limitations of those. Now, what people have done is they've done loop tapes. You may have heard of this. The people on the tape will talk about their obsession. We just had a guy do this who feared he was a transsexual over and over again. He would talk, I'm a transsexual. This is awful. This is terrible. My life is going to end. Blah blah blah. And he would do this for an hour and a half, and then for an hour he would listen to the tape, and boom, the obsession was gone within a week. So it's real interesting stuff. But those are one of the good cases. A lot of times they don't respond that way. So I want to move on to what I call the mask of OCD, and this is what ties into kind of this conference and personal meaning and existential issues and things like that, is that OCD wears many masks. And if you remember, I said that there were 3 types of obsessions: sex, religion, and violence. And a lot of times OCD will just put one on mask and put another mask on. And so I think it's really important as therapists to kind of recognize that when somebody comes in and they have an obsession, to recognize that this could be a part of OCD. Okay, that this could be a part of OCD. And to realize that this may not necessarily be something deep within their character structure that's inherently wrong, or that sometimes long-term analysis, matter of fact, the research shows that long-term analysis with these types of folks, actually they stay the same or they get worse. So you got to be real careful with these folks, okay? And especially now with the whole 911 stuff, these people come in and they have these obsessions. I've seen these people more and more. And I think in the 911, like the meaningful thing of it is that people began to see what they didn't appreciate in life. They began to see those things, and I think those are great, wonderful things. And a lot of people have returned to faith, and they've returned to some of their basic values and things like that. But we also need to remember that OCD will grab onto things. And so a person who comes in who may be tormented with a thought that they're not good enough, or a thought that something's wrong with them or something like that, you may want to think that a little red flag might go up, and you might think, oh, this person may have OCD. So, okay, let me move on here and become a little bit more specific and talk about the patient that I saw briefly. And I've got a videotape. I'm going to show you what we did with this patient and kind of the creative process that OCD has itself of trying to sustain itself. But what I wanted to really emphasize is, first of all, when the patient comes in and they have obsessions and compulsions, we need to do a real good assessment of them, okay? And I'm sure, in graduate school and training and all that, they talk about the importance of conceptualization, the importance of assessment. This is real important with OCD patients. One of the things up there, I didn't write it up there, but there's an assessment tool called the WBOGS. It's WBOCS. And the long name of it is the Yale-Brown Obsessive Compulsive Symptom Inventory. That's right. It's a really good instrument. It's called the WBOGS. It's actually Y, and then there's a hyphen, BOCS. It's really good because what it does is it breaks down obsessions versus compulsions, intensity, frequency, duration. So you get some really good evidence, really good information that kind of helps elicit this from the client, so that you have kind of a guideline to go through. Okay, so this can be usually done. What we've done is usually in our second session with these folks, is we give them the WBOGS. The first session is let me get to know you. Tell me what's going on. And the second session is, okay, let's fine tune this and let's kind of see what's going on. I can't overstate how important this is, because this really directs your treatment. Do not further engage the patient in their obsessions and compulsions, okay? Especially their obsessions. Frankl talked about this a lot. He said that the worst thing you can do is engage somebody in their obsessions. You want to really provide a model, kind of an educational, if you want to call it a cognitive behavioral model, whatever kind of model to help explain to them what's going on. And the model is basically this. There are triggers that are happening throughout the day for them. They're having thoughts and reactions to these triggers, okay? These thoughts kind of evolve themselves, and the person experiences anxiety, depression, overwhelming feelings of panic. And so what do? They neutralize, okay? That's what we talked about before. They do their compulsion, okay? So the other component of this is You got to think about what are the neutralizations, what are the compulsions, what are these people doing that doesn't allow them to experience the anxiety. So you have a model that you explain to the patient, and the patient can always go back to the model. And the patient really has to buy into this model in order to really understand how the OCD keeps being triggered. Okay? And then you almost provide, if I can use some interpersonal stuff, kind of like a corrective emotional experience, if you want to use it that way. But in sessions, you kind of do you show them how you're going to change the model a little bit, and you're going to show them that they can stand their anxiety, like Ellis would say, that their anxiety is extremely frustrating, but they can stand it, and that they don't have to resort to these neutralizations, to these compulsions. Okay? Issues that may have led to these things, the people are just they're not going to go for it. I mean, some will, and ethically, we want to give them symptom relief. We want to help these people. Now, we can do all those other things, and we need to do those other things, the longer-term therapy with them, you know, interpersonal approach, whatever approach you have. But first, when they walk in the door, these people are suffering. Okay, I can't emphasize that enough. So, what my client, my patient, what did I do with this person? Well, first of all, I did co-therapy with my supervisor since I'm a graduate student. So I did co-therapy, and I was part of the OCD clinic there, so I strictly worked on the OCD component of this, and then the therapist, my supervisor, worked on more kind of enduring issues and things like that. But let me give you just a real quick synopsis on this patient. She's a 35-year-old, married, female, Caucasian patient. She had several young children. She reported a history of generalized anxiety basically throughout her life, okay, which was exacerbated and turned into full-blown OCD after 9/11. Okay. The patient also had 2 significant losses within 2 years in her family. One of them was her grandmother, who she was very close to. Okay. So immediately, as the patient begins to tell you this information, you can, as we all do, we can start going, okay, blah, 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 loss, and then you see 911. You could start coming up with all sorts of rationales and things about how you might want to put this together. Those are great, but first what we need to do is we need to deal with this obsession, because this person is coming in tremendous amount of pain. So, you get that information. Let me see if there was anything else about the patient that struck out. She did have some comorbid depression as well. Let's see if there was anything. Oh, she worked at a railroad company. She had a lot of anxiety on the job as well. A lot of her obsessions were terrible, just images of flying. And I'm sure the media doesn't help with that. It's one of the tools we use to help her. She couldn't go on an airplane. She couldn't fly. It was a harm obsession. Something's going to happen to her. Okay, so the other thing was a harm obsession of her children. Something's going to happen to my children all the time. She was hypervigilant. She did a lot of neutralizations during the day. Compulsions, constantly looking around the kids all the time, over and over and over again. During the day, the news would come on about 911, and while it's true that, as people told us at that time that, don't listen to that stuff over and over again because it'll drive you batty, she went to the other extreme. The second she heard the news, turned it off. So now we're turning into a neutralization, to a compulsion, because she didn't want to experience some of that anxiety. So she really went kind of the other way. So if a newspaper saw a newspaper, I don't want to see the newspaper. She would walk out. If she'd see anything that was like harm related or 911 related, she would just, I don't want see it talk about anything else. And her OCD was getting worse and worse. She would spend hours just plagued by just these images and just all these harmony sessions. Let's see. So, like I told you before, we did an assessment. We didn't further engage her into, blah 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 blah. Try to begin some kind of in-depth analysis with her. We explained to her the model of OCD, that there were triggers that she's neutralizing throughout the day, and she responded very well. And it really only took about three or four, basically 3 weeks, and most of her obsessions were pretty much gone. Okay. The way we did this is we used exposure and response prevention. I'm going to show you here what we did. And I'm going to stop the tape for a second. I'm going to show you how insidious OCD is, because it was even interfering with the treatment. We asked her permission if we could use a media tape from 911 and have her watch it, in the session with us there. So we're also using modeling and the collaborative relationships that were there for her. And we wanted her to make some predictions. Okay, what's your anxiety level going to be on a scale from 1 to 10 as you're watching this tape? Oh, a 10. It's going to be horrible, terrible. I can't do it. Okay, well, let's kind of watch this for 15 minutes and let's re-rate your anxiety level and see kind of where it goes from there. And you have to be a bit persuasive with these clients because they're so afraid of this stuff. Anyway, let me show you what we showed her. And as I even see this, my anxiety went up, so I can imagine how this lady was feeling.
Warnings effective. Here to talk with us now, a man who knows a thing or two about the threat of terrorism on U.S. soil, former FBI Chief of Domestic Terrorism, Robert Blitzer. Mr. Blitzer, good morning. Nice to see you, sir.
Nice to see you.
There's a story out of Colorado that a lot of people might not have heard about, luckily, because it does not seem as though this threat is too serious, but FBI agents, as I'm sure you know, were worried that somebody might have been trying to plan an attack on the Hoover Dam. What kind of plans are in place to protect the dam and other spots around the country?
Well, Rick, since September 11th, there's been a whole lot of effort to bring the National Guard into a lot of these particular major critical infrastructure nodes, and to try and beef up the level of security around them so that they're not easy targets.
Well, it seems, though, that symbols are important to terrorists. The Hoover Dam obviously serves a purpose for people who live in the southwestern part of the United States, but the World Trade Center, of course, the Pentagon. Word last week that perhaps the Liberty Bell in Philadelphia might be a target. We have these symbols.
Okay, I'm going to stop this for a second. I'll go back. Now, the reason I said notice the little thing on the bottom, how those news stations have those. Okay, what she was doing is she was watching this, and initially that day she was feeling a little better, so she rated her anxiety around an 8. She's looking at this tape, and we stopped her for 15 minutes. We asked her, okay, where's your anxiety level? It's like a 7. And we're like, okay. And then we asked her, well, what were you doing as you were watching this tape? Well, I was distracting myself because I was reading the bottom of the screen, the little things down there. Now, that is a neutralization, okay? And if you don't ask for these things, you've got to really elicit these things. It takes some skill to do this, and my supervisor, thank God, had the intuition or whatever it was to ask about, well, what were you doing here? So he said, okay, for this to work, you need to not do that. You need to really focus on what they're saying, okay? So she was like, okay, I'll do this. And so that's what she did. So we played it some more. Oop. Thank you.
National Guard into a lot of these particular major critical infrastructure nodes, and to try and beef up just the level of security around them so that they're not
and we
easy
would check
targets.
in with her from time to time.
Well, it seems, though, that symbols are important to terrorists. I mean, the Hoover Dam obviously serves a purpose for people who live in the southwestern part of the United States, but the World Trade Center, of course, the Pentagon. Word last week that perhaps the Liberty Bell in Philadelphia might be a target. We have these symbols all over the country. Is it possible to protect them all?
Gee, Rick, it's almost impossible to protect them all, but...
so afterwards, she was like down to a 4. And she became, like, in the spirit of George Kelly, kind of her own personal scientist. She realized that her anxiety, that, you know, she went through this experiment and her anxiety actually went down. And so what we did with her is, you know, every opportunity she had during the week to listen to this stuff, you know, avoid the neutralizations. And within a few weeks, she was no longer plagued by these OCD sessions. And then my supervisor kind of took over and worked with longer-term issues, interpersonal issues, especially some of the losses that she had gone through and those other things. But more importantly, he integrated into a model where the OCD worked into all of that stuff as well. So that was her. Now I've heard, let's see, last time I heard from her is about a few weeks ago, and she's been able to go on a plane now, so she can fly, which was incredible because every time she could think of a plane, she'd get all nervous. So conclusions, just very briefly, would be one, that I think cognitive behavioral therapy can be a powerful existential vehicle of change. Okay. First, when these folks come in, we need to do proper assessment. We need to use mainly this type of behavior therapy, and we also need to use a model, an educational model. Okay. Like Frankl said, we need to stay away from engaging them in their obsessions over and over again. And lastly, we can certainly use more meaning-based interpersonal approaches, but those need to be things after you deal with this initial symptom relief for these folks. And that'll also help with longer lasting change. So that's the end of my presentation. If you all have any questions about... Yes? The meaning? Or is it part of her ethnicity and her being? Well, I know that some of the stuff was, she did find herself to be kind of very vulnerable. She described herself as vulnerable, especially because of some of these interpersonal losses that she had within like the last 2 years. But before that, she said that she considered herself, the way that she saw herself, was somebody who was in control, somebody who could kind of handle life, as a healthy individual. And so this disparity that now she was just filled with anxiety and with terror was a real problem for her, because she went from what she felt, was being this person to just somebody totally out of control.
Did she indicate how close she was able to manage this in the past?
She really, in the past, she generally had free-floating anxiety. She didn't have anything as severe as this. So basically, what she talked about, her general anxiety was just kind of I would just tough it out. She would kind of just tough it out with anxiety. And that was pretty much her approach to things.
No spiritual religious ideology or anything?
She didn't really have like a spiritual background. She basically, the way that her background was, I don't think her family, they were not religious, because we assessed for that, was a religious spiritual background there. She wasn't particularly a religious or spiritual or faith type person there. She'd just been kind of a hard worker all her life. And especially with working at the railroad company, she was used to being tough with kind of these men that were there all the time and kind of being in control of things.
Let me ask, why do you think this effective?
Part of it could go back to the issue of control. You know, the fact that, and that's part of what the model is that she was able to gain control, is that she was able to see that I can stand kind of this anxiety and that I can tolerate this. So it may have been a way to kind of, you know, help her regain some of that control over her life. That could be a possible attribution. Yeah. Yes?
Do you see any comorbidity with head injuries at OCD very much?
Some. Definitely, like a lot of times there's neurological problems, you know. But yes, there are some people who have head injuries. Now, personally, I've seen more people that just have comorbid things that kind of look like autism and things like that. But I know that the research shows that there is a little bit, you know, head injury. Yeah. It could very well be, yeah. Especially if there's problems with the frontal lobe and, you know, things like that. In OCD, they implicate the amygdala and different specific areas of the brain, different organs connecting, you know, brain structures connecting with each other. You know, that's again from the biological approach. Any other questions? Sure. Yeah.
Would you be comfortable with the fact that in a sense you could talk in theology? I use that word deliberately. And it was cued, but for me, it was cued by your comment. You taught her to be a personal scientist in George Kelly tradition.
Right.
And that's, for me, a form of meaning making. And it's not new. It's reinforced by our culture. Yeah.
Sure. My comment with George Kelly was that he said everybody is personal scientists. So all of us are, and we're constantly trying to validate and revalidate our constructions of reality. And that's one of the problems with OCD is that they don't take the risk to validate or to kind of experiment. But I think what your question is did we teach her something new? Like you said, it's not value free. You know, did we teach her something new? Yet we taught her some tools, like how to use this, how to deal with OCD. So yeah, definitely there was a big educational model to this. There's definitely.
For Kelly to say that everybody is like this is a form of theology.
Sure. But Freud and everybody else has their own ideas about things, and just I referred it to Kelly just because what Kelly said is that we all are constantly struggling to make sense of our world, and we just all have experiments and things over and over again. And I was just using that model to show that kind of she became to kind of give her the credit. She's the one who kind of was able to rearrange her constructs and way to look at the world.
If this had been a very religious, spiritual person, I would have taken considerable offense with this particular approach at that particular time, unless there's a major consideration of consent.
And there's a really good Cherokee. He's a Jesuit priest who wrote a book called The Doubting Disease. And he talks about OCD and how OCD doesn't have to do with religion. You know, it can mask itself as religion. And a lot of times that can actually be a hindrance with the patients, is because they'll come in and they'll be so afraid that, you know, the spiritual beliefs will be changed. And so you really have to talk to them. Sometimes you get the minister involved, their pastor, to really, so that they can feel safe, that they're not walking away from their faith, that they're not doing something like that. So yeah, there's times when we've had to do that. But I understand. You know, like I said, it's a very tricky disorder. It's very different.
We'll let you discuss that later. Thank you very much.
Thanks.